I am here with Dr. Barry Rosen. He is a Cubs fan, but he is also a surgeon with the Advocate Medical Group in Barrington, Illinois. It is so nice to meet you.
You as well, Hannah?
Yes. What are 3 things that patients should know about DCIS?
Okay. Well, there's a lot they should know.
I know. Give me the top 3.
Top 3.
Yeah.
First and foremost, as I'm sure you'll hear throughout the day, it is pre-cancer.
Yeah.
It is pre-cancer. It's not about survival, it's about local recurrence. It is, in many ways, it's the ultimate preventive surgery. We're doing that to prevent someone from getting true or invasive breast cancer.
Okay, that's number 1.
Number 1.
Okay, what's number 2?
Number 2 is that our concern is local recurrence. If we surgically treat that DCIS, what are the chances of that cancer growing back? And if it does grow back, will it grow back as invasive cancer or DCIS?
Okay.
And then 3.
Okay.
Number 3 is, yes, radiation therapy can be very effective to lower recurrence rates, but it is not necessary for everyone.
That's really outdated thinking, right?
It is.
That everyone has to go through radiation.
Yes, and across the spectrum, we've gone for cancer treatment for doing one size fits all to really trying to move more to precision treatment and trying to guide the therapy, the least amount of therapy to get to the best outcome.
So that you're not over-treating patients.
Exactly.
Right.
And radiation, you can't see it, but it's a gift that keeps on giving, regrettably for many women, for the rest of their lives.
Yeah,
So-
what are some of the effects of radiation that you might have to deal with? And we're talking about younger and younger women getting cancer too. So you're
Yes.
talking about, decades of life after the fact.
Yes, and it's interesting because not everyone has the same response.
Sure.
But for many women, you get fibrosis, you get scarring in the breast, and that could manifest itself in the change of the shape or size of your breast. And for a lot of my patients, if you ask the right questions, just being hugged hurts. So there's a chronic discomfort that can go along with that. And so we tend to minimize radiation because compared to chemotherapy,
Sure.
it's very simple. But the effects are real, and if you could avoid radiation,
Ooh.
you'll have a much better outcome.
Yeah, how critical is Decision RT in really helping doctors and patients understand if you need radiation or not and how much?
It's transformative. It really is. And if what we know, we've been studying this for 40, 50 years. And what we know is that if you look at DCIS patients, only about 50 to 70% really would benefit significantly from radiation therapy. So
Wow.
almost half patients won't benefit that dramatically. Yet, in my own personal experience doing this for more than a few years, it seems that most of the women who I send to the radiation oncologist get radiation therapy. There is a disconnect there. And we've been going by traditional
So like ClinPath, let's talk about that, because
Yes.
if you had a colleague who wasn't using Decision RT and they're still using ClinPath, like what would you tell that person?
I would say that it's time to come into the 21st century. There's the World Wide Web, there's HD TVs. You don't need black and white TVs anymore.
You don't even need cable.
You don't even need cable, exactly. So you really have to take the best of what's out there. And it's not that the clinical path's irrelevant, it's very relevant, but you add an additional layer onto that with Decision RT, and it's knowledge that will empower our patients to make better decisions for themselves.
How do you use it in surgical planning?
Well, we can use a lot of sports analogies here.
Oh, let's do it.
Yes.
Please
Okay.
do. Okay, good.
Breast cancer treatment is a team sport, Hannah.
Yes, I love it.
And it's part of the joy of doing this is that you really have to work well with your colleagues. And so you bring in a radiation oncologist and a medical oncologist, and you meet to discuss every patient ideally. And there are going to be 3 types of patients with DCIS. Those who clearly do not need radiation.
Right.
Those who clearly do. But then the largest category are these people where it could go either way. And we, as a team, decide this is the right layer of testing to do to really help make that decision a little more binary, a little less gray.
Yeah, I mean, but you need the information, right? Like it's right there to help you make that decision.
Get that result in a week. When you tell patients, they don't have to go through any other biopsy to do it.
Yeah, it's amazing.
And if you talk to your patients, you'll be hard pressed to find someone to say, no, thank you.
Yeah, exactly.
I mean, yet to find one.
Right.
Yes,
I mean, it's so easy to understand too as a patient when you look at it. You look at the data and you're like, oh yeah, I get that. And thank you.
Yes.
And see you later.
Yeah.
You know?
Would have loved to, but
yeah.
Yeah.
The radiation oncologist, it's kind of mind blowing when you talk about how transformative this technology is. That there is still a group of people who kind of pushes back against like Decision RT, and I don't really understand that.
Yeah, I think just like any innovative technology, you have the early adopters,
Right.
and then you have the followers.
Right.
And cancer care is very much so guideline driven, but the guidelines lag behind innovation. And radiation oncologists, medical oncologists are taught to be conservative. I respect that. But there has to be some times where you look at common sense
Yeah.
and you say, this is something that can really impact that person who's sitting with you that day's result. And I think that certainly the innovative radiation oncologists, the early adopters, they're all, but it's the laggards that we sort of have to pull in.
Let's go.
Yes, it's time.
I think, you know, when you talk about a woman like feeling that, like when she hugs another person, like after radiation, and you think that that's something that could be avoided. You know what I mean? It's just, it's got to be like a complete, to use another sports analogy, game changer for you.
It is. It is, and I don't know that we emphasize that. And when we talk about radiation therapy, we talk about, you know, transient changes to the skin, like sunburn-like reaction. We talk about lethargy. Sometimes women are a little tired. But we really minimize. We say, oh, it's really so easy.
Yeah.
It's, you know, it's like going to 7-Eleven. You go in for 10 minutes, you leave, you do it, whether you're doing it for 3 weeks, 4 weeks, but it's what continues.
Yeah, I mean, that's really like not supportive of the patient and what she might go through. I mean, it kind of follows a pattern of, I don't want to say a lack of respect, but maybe a lack of awareness of, you know, what women are going through, the totality of what they're going through in terms of treating DCIS,
and
right?
you have to look at it through the patient's eyes.
Yeah.
And it's not, when you see someone whose breast has shrunk or the shape has changed, it's not vanity, it's a reminder, it's a daily reminder of the cancer they had.
Yeah.
And moving forward means that if you don't have those reminders, it becomes a stage in your life that passed. And that's ultimately,
so well said.
Every woman is different. Every person is different. But we all want the life we had before this bomb went off in our life.
Yeah.
It said, you have cancer. And it's the subtle things, like the cosmetic changes, that really can linger forever. And you can't minimize that.
Okay, finally, one word you would use to describe the impact of Decision RT.
Clarity. It gives you clarity. It takes an ambiguous situation, like do you need radiation, do you not? And it gives us this precision, this layer, that's 2 words, sorry. This layer of clarity.
No, you can use 2 words, I'll let you. Clarity.
Precision and clarity.
I love it.
There we go.
I love it. Thank you so much.
Hannah, it was a pleasure.